Thank you very much. I think we have to stop questions and we can pass to the next speaker, Professor Ceresini from University of Parma, that is going to talk about thyroxine treatment of benign thyroid nodules.
Mr. Chairman, dear colleagues, let me thank Dr. Valcavi for inviting me to participate in this very beautiful meeting. Well, the topic is actually a question, and we will go through a path to try to answer this question. And this path, over the years, was sometimes not so straight, and we will see it during this talk. So this kind of treatment has been considered a therapeutic option for benign thyroid nodules, as we know. The aim, obviously, is to suppress TSH and to obtain a reduction of the growth of the thyroid nodule. And such use of this therapy has been invariably recommended in the past, as we know. And I'm pleased to start this talk with a paper from an Italian group from Papini, actually. Dr. Papini is here and is one of the recognized speakers of this symposium. And they, back in 1998, did this very interesting study, and they studied 83 patients who were randomly assigned to levothyroxine suppressive therapy or to a control group. And as you can see here, this is the LT4 group. There was a tendency to decrease in a treatment period of 5 years. This reduction of the volume was not significant, but the trend was very nice. On the contrary, in the control group, you can see quite nicely that the volume increased significantly over the study period. And this is the TSH they obtained during this study. As you can see, they obtained a suppression, basically, of TSH in the treatment group, and no changes of TSH, obviously, in the control group. And they concluded the long-term TSH suppression induced volume reduction in only a subgroup of thyroid nodules. However, this treatment prevented the appearance of new lesions. And related to prolonged TSH suppression, which can induce unfavorable side effects, they say that this treatment could be reserved for small nodules in younger patients. In 1998, again, another group did this kind of study looking at 21 levothyroxine treatment patients versus 24 patients treated with placebo. Please look at the low number of this patient in both arms. And what they found was that TSH actually was reduced, was basically suppressed, and at 12 months, this was the duration of the study, was close to the suppression level, but not actually suppressed. The volume didn't change significantly, didn't change at all. So, negative results. And this is a study in 2002 from a French group who studied 123 patients in an 18-month treatment with LT4 or placebo. In the upper part of this slide, you can see in the black portion of these results, those who responded. Responded means that they had a shrinkage of the nodule up to 50%. And this is the LT4 group, and this is the placebo group. And as you can see, this is the proportion. 26% had a reduction of thyroid volume in the LT4 group versus 16% in the placebo group. The gray area represents the partial responders which means that they had a nodule reduction which was between 20 and 50%. And as you can see here, the percentage of partial responders was around 20%, and in the LT4 treated patient versus 13% in the placebo group. Yes, there was obviously a difference between this proportion, but for a certain point of view, you can also speculate that the gap between the responders and the non-responders, although significant, was not so wide. In the lower part of the slide, in this part, you can see what happened to the remaining portion of the thyroid tissue, so new nodules, or disappearance of the nodules which were not the main nodule. So again, improvement in the black portion, 9% in the treated group, no improvement, no disappearance of nodule in the placebo group. Worsening means that new nodules appeared, 7% in the treated group, in the LT4 treated group, 13% in the non-treated group. But if you can see here, the portion which had no change was almost comparable between LT4 group and placebo group. And this was one of the first meta-analyses on this topic. And as you can see here, a tendency toward a positive effect, so it means shrinkage of the nodule, was there, but that was a tendency that was not statistically significant. Another meta-analysis appeared in the literature in 2005, and you can see here, these are the studies which were taken into account in this meta-analysis, and an effect was there, actually. It was not so great, but definitely was statistically significant. However, the author stated that 8 patients would need to be treated with this therapy in order to have 1 responder. In other terms, the number needed to treat in this study, in this meta-analysis, was 8, although the RR was 1.88, so actually significant. The author concluded that given the number needed to treat, they estimated to be high, and the side effect of thyroid hormone suppressive therapy, questionable effectiveness of this long-term use, and we have to note that the regrowth following cessation of therapy. Because of this problem, the routine use of this therapy for benign nodules was not recommended as a concluding remark of this paper. And actually the fact that thyroid hormone FT4 therapy for benign nodule may induce some adverse effect is true. And basically what we have in this patient is the effect, the systemic effect of subclinical hyperthyroidism. And we know that much of the systemic effect of subclinical hyperthyroidism is played on cardiac system. These are a paper from our group in which we demonstrated that subclinically hyperthyroid subject, you can see here in the blue dotted line, had an increased all-cause mortality over a 6-year evaluation as compared to euthyroid subject and subclinically hypothyroid subject. So these are subjects who are 65 or more older, and definitely they are not the candidate for TSA suppressive therapy, which is the talking of today. But we also did another study within the International Thyroid Study Cooperation Group. This is an international consortium of, and in this case, we studied more than 30,000 people And we evaluated what can be the cardiovascular effect with the thyroid hormone variation within the normal reference range. Okay, by studying this kind of subjects, we found that if you compare the 4 quartile of TSH, so pardon me, of FT4, so FT4 within the normal range, but at the upper limit of the normal range, with the the lowest quartile, you can see here that there is an increased, significantly increased risk for atrial fibrillation. And this is something we have to take into account when we talk about LT4 therapy for this kind of disease. Well, some authors tried to see whether if we use LT4 with a non-suppressive aim, so the goal is to maintain TSH close to the lower limit of the normal range, but not suppressed, to see if the volume of thyroid nodule presents some variation. And this is what this group from Turkey did back in 2002, actually. What you can see here is that this continue line represents the subjects who were submitted to a suppressive therapy, TSH equal or below 0.1. Conversely, the dotted line represents patients in which TSH was maintained between 0.4 and 0.6 milliunit per liter. And as you can see, the volume of the nodule shrank, there's no doubt, in both treatment. That is to say that probably a TSH close to the lower limit of the normal range, but not suppressed, may be effective in producing a volume reduction of this nodule. In the upper part of the graph, you see this patient treated with placebo, and as you can see, the nodule volume increased after 1 year. At this point, all the arms were shifted to the the opposite treatment. So that was a crossover actually design. And when this arm started to be treated with both of the treatment regimen, as you can see, the volume was reduced. On the other hand, in this kind of subject, when the both suppressive therapy and non-suppressive therapy was stopped, the volume started to increase. This was an interesting paper. Unfortunately, in the literature, there was basically no other paper demonstrating this kind of effect of non-suppressive TSH, of non-suppressive dose of LT4. And another meta-analysis was presented in the literature. These are the results. These are the studies which were taken into account in this meta-analysis. And as you can see here, the effect was positive, was statistically significant, but the RR was 1.68, but again, the number needed to treat was 6. In other terms, this author found that we need to treat 6 patients in order to have 1 responder. And let me open a bracket. The feeling in our everyday life is that probably this number needed to treat should be reduced. We have positive effect, we have to say that, of LT4 therapy in benign nodule. But these are the data of the literature, and we have to face this data, we have to face these results. But we have also to consider that differences in between and among different studies exist. For example, the geographic areas are not the same in the same studies. And I believe that all of you agree in the consideration that probably a population from iodine deficient area may behave differently from a population who lives in an iodine sufficient area. And the genetic of population, again, may play an important role in explaining this difference between studies. And if you go back again to the meta-analysis we have seen before, okay, those studies are from different countries with different genetics of population and with different iodine content. And we have to take into account all these characteristics of that study. Again, nodule size at baseline may explain some difference between studies, the nodule composition, and the cutoff for defining size reduction. And finally, the treatment duration. We have studies who lasted 6 months versus other studies who continued for 5 years, as we have seen before. So in 2016, 2015, actually, the American Thyroid Association stated that the routine TSH suppression therapy for benign thyroid nodules is not recommended. The modest responses to therapy can be detected. Again, the potential harm outweighs the benefit. And this is what we have seen up to now. In the same period, an Italian group from Rome, La Sapienza, did this interesting study. They surveyed this population in a multi-center study, Italian study, this is an Italian study, in a multi-center study for 5 years. And they studied 992 patients with 1 to 4 asymptomatic, sonographically or cytologically benign nodules. The total number of nodules was 1547. And as you can see, what they found was that a proportion of this patient, and we say of this nodule actually, remained stable over a year. I remember that was a survey of 5 years, remained stable over years, whereas others increased in their diameter and some other decreased in their diameter. When they considered the volume, the trajectories were the same. A proportion increased, another proportion remained stable, and another proportion decreased in their volume. What was interesting to know, to see that if we make a calculation, we see that almost 80% of this nodule remains stable over time, whereas 11% grew over time and 13% shrank. So this is basically an important result for an Italian population, and this doesn't necessarily mean that these results may be translated into other populations, but this is what we have in Italy. And what the nodule who grew were associated with in this study. As you can see, taking as a reference women, male have 1.7 odds ratio. So male sex may be something which is related, associated with nodule growth. Age of the patient, taking as a reference age less than 45 years, you can see that age higher than 45 were not associated with an increase of ratio to have nodule growth. No effect of BMI, whereas an effect was found for number of nodules. The higher the number of nodules, the higher the probability that nodules grow. And also for volume of the largest nodule, an association was found. As you can see, the higher the volume, the higher the probability of having a nodule growth. And I didn't went into detail of this study, but there are few studies on large cytologically benign nodules. And these authors studied this nodule, and to be brief, I reported only the conclusion of this group. They say that cytologically benign, so Bethesda 2, asymptomatic nodules with large size, higher than 3, 4, 5 centimeter, may avoid surgery and be clinically observed. In this conclusion, this author did not talk about LT4 therapy. So basically, we'll try to answer the question at this point, saying that the role of this LT4 treatment has been greatly questioned. There's no doubt on that. The average nodule reduction is 5 to 15%, with serum TSH ranging from 0.2 and 0.1 millunit per liter. And obviously, concerns have been raised, especially on cardiovascular system, as one of the main side effects of this therapy. But again, probably in our experience, we have proportion and percentage of responders which are higher than those reported in the overall consideration of the literature. The number needed to treat, again, is quite high. 6 to 8 patients have to be treated in order to have one responder. And on the other hand, we have also to consider that according to the study, the Italian study we have seen before, the vast majority of thyroid nodules remain stable over years. However, an open question may still be represented by nodules who are part of a multinodular goiter in male sex of a diameter which is higher than 8 millimeter, and in people aged less than 45 years. So probably studies are lacking on this kind of population. Data on large MAB symptomatic nodules are scanty, but I believe that this is at least in part the reason why we are here today. Thank you very much for your attention.
Thank you, Professor Cerecini. I want to make a question to Professor Cerecini. In your presentation, you talk about some side effects of levothyroxine therapy in thyroid nodule, mainly heart, cardiovascular problem. And what about bone, especially in female? What is your experience?
Yeah, I didn't talk about that because I wanted to be
right
in time, actually. And but this is another problem, actually, obviously. Consider that there are data in the literature on women who had Graves' disease, for example, before menopause. Well, these women didn't have, after menopause and after the treatment of Graves' disease, a bone density as was expected if they were not affected by hyperthyroidism. So subclinical hyperthyroidism is obviously, we have a very numerous evidences from the literature may be detrimental for bone. And actually, what we knew and what we know up to now is that if we decide to treat a woman with this kind of treatment, we have to stop this treatment after menopause. Probably, of course, because of this problem associated with a cardiovascular risk that we know after menopause start to increase. But definitely bone is another main topic to be considered in this kind of adverse effect.
Thank you, thank you. If there are no questions, we can stop this section, and thanks, Professor Ceresini.